The most interesting finding is counterintuitive. The most important thing during this procedure, focusing on dissection of the finger extensor.
Hello and welcome to another episode of The Rest is Plastics. My name is James Chan. I'm your host and I'm on my lonesome today because my buddy Anton Fries is not available. So, vascularized joint transfer for PIP joint reconstruction. A technically demanding operation, and one of the most challenging aspects is being able to fix the proximal phalanx end well. And so some patients will go on to have malunion or non-union. So the question is, will a malunited proximal phalanx affect the outcomes of vascularized PIP joint transfers? And that's the title of the paper we're discussing today. And joining us are two of the authors, Professor Ted Lin and Dr. Ike Lee, both from the Chang Gung Memorial Hospital in Taiwan, and they have a huge experience of this type of operations. And Professor Lin, of course, many of you will know that he spent many years refining this technique, and he's published many papers on how to get the most out of this reconstruction. So this is a wonderful episode. I learned loads and I hope you will too. Ike and Ted, thank you so much for joining us on The Rest is Plastics. It's a real honor to have you. Ted, you've spent many years refining the art of the vascularized PIP joint transfer, and this is your latest paper in JPRAS, published last month in April 2026, and also with the front cover illustration. So thank you very much for that wonderful paper. The paper is called "Will a Malunited Proximal Phalanx Affect the Outcomes of a Vascularized Joint Transfer in the PIPJ?" So why did you choose to study this topic?
Well, this topic actually is coming from a clinical frustration, actually, that during our joint transfer, we always focus on the final range of motion, especially for the extensor leg. But over the years, actually, we already overcome some of the extensor reconstruction technique and improve the rehabilitation protocol and even the so-called osteosynthesis methods. But so far that we still notice that in the long run still has some case actually their outcome, their result is under average. Although the average result looks nice, but well, end up they still have some cases that will not be as satisfactory. And we notice from the follow-up of the those X-rays, and we found out in a group of patients, actually, they could have some malunion or delayed union or even non-union. And we just wonder with this kind of malunion, non-union is a factor that to give a worse in the outcome. So that's why we started to analyze this problem. Of course, that just because we already had pretty much amount of cases, and we try to find out every possible reason that the outcome actually is under the average.
Right.
So that's the reason we studied this.
Yeah. So so trying to refine the method to give even better outcomes, and the hypothesis or the question is whether a malunited proximal phalanx would give people inferior outcomes. So I guess that's the premise. So how did you go about looking into this? What was the methodology?
Actually, first, of course, we have to define the malunion. We will make it as a dorsal angulation that is greater than 10 degrees, and that's a group of patients that we call them malunion. And of course, that we still try to analyze the serious radiograph over the time. And we try to compare the immediate post-op alignment and later follow-up alignments and to see if there's some progression of the dorsal angulation. And we also try to look at the non-urine rate and some secondary procedures such as corrective osteotomy and tenolysis. Those was quite common secondary procedure after the vascular joint transfer. So we also, at the same time, actually, we also examined our fixation method. Actually, in the past, at the beginning of my practice, I used parallel suckerage vials for the fixation. But later on, I will combine with an additional 90-90 vial to get a better stability of the vascular joint. So with that, and we try to identify the possible will those cases with a malunion will have inferior outcome
Mhm.
comparing to those with a union in time.
Yeah, so that's really clear. So it's a retrospective study and conducted over a long period of time from 2008 to 2022. So that's 14 years worth of work. And just
Mhm.
t tell us how many cases w were involved and how many did have the malunion.
Actually, we have 60, well, if you say we have about 67 cases that with a regular follow-up
Hmm.
in our series. So although we have about more than 100 cases, but we try to include the cases that be followed for more than six, at least for more than 6 months. Yeah, if the patient did not follow as long or did not compliance to our rehab program, then we will not include the patient into our series. And in our cases, we still have about 15% of cases, 10 to 15% of cases will have some malunion. Well, in this study, actually, we try to include as many. So no matter is what kind of mechanism of injury, and we include them for these studies. Yes.
Yeah. And so a huge number of cases and lots of experience in your unit. Would you mind summarizing the findings for our listeners?
The most interesting finding actually is, well, you can say it's a counterintuitive. Initially, we thought about malunion might have a worse outcome, but after our study, actually found out that the malunion was not a real uh, factor that affected the final outcome. And from the study, actually, how we explain those cases with um, who will have the malunion, one of the reason actually is, should be related to um, the anatomic mismatch between the toe and finger at the proximal phalanx level. In the toe, actually, the proximal phalanx is more likely vertical in the appliques, but in the finger, actually, is horizontal.
Hmm.
So that make the osteosynthesis actually with some difficult. But some other reason may be related to the puller perfusion. Although the flap all survive, but the perfusion will kind of be affected by uh, the smoking.
Mm.
So actually, we use laser Doppler to follow our cases, and we, we also found out that the smokers actually had the poorer perfusion and in the monitor skin pedal comparing to those non-smokers, and their clinical outcome actually was not as good, and they had the inferior range of motion and even worse fraction recovery.
Yeah. If I may just jump in to just for our listeners, because I've had the privilege of coming to see you do these operations. is that you incorporate a skin paddle as part of your
Yes,
PIP joint transfer, and that's a
yes,
monitoring skin paddle, and that's what you use the laser Doppler for. Is that right? To measure the
that's right.
perfusion. So that's a
Yes,
surrogate marker of how well the perfusion is for the underlying joint transfer.
yes.
Okay, so you found paradoxically that actually the patients who went on for malunion and non-union didn't actually have a worse outcome in terms of their range of motion post-operatively.
Exactly.
Yeah, and but the patients who were smokers seemed to have a slightly worse perfusion of the skin paddle, but they were the ones who had more stiffness at the end of the day.
I I can suspect these patients will have some, they will have more likely to have some malunion. And the- for those cases with a delayed union, I think even the rehab program cannot be processed very confidently by the patient or by the therapist. So we will do it more conservatively in the rehabilitation programs. So kind of delay in starting active range of motion and kind of delay in more aggressive range of motion exercise. I
Mm,
think that's also affect the final outcome. But of course, the other thing is that in our previous studies, actually we found out that in our series, basically patient, we have about more than around 50% of cases who do need a secondary revision, that is so such as a tenolysis or some correction osteotomy in earlier cases.
mm,
So at the initial outcome, those malunion or those delay union may not have as good in the range of motion. But after tenolysis, after release of those adhesion problems, and actually those patients still can get pretty good results. So for the malunion group, that's why we said that for those with malunion or those with the normal union,
mm.
actually the final outcome didn't have a great difference in the range of motion, actually.
Yeah. And
Yeah.
just it was fascinating what you were talking about, the technical tips about in figure one of your paper, for example, you've got this beautiful illustration sheet that made it to the front of the cover of the
Yes,
issue. So, so you were depicting how the cross-sectional areas match up much nicer in the middle phalanx compared to the proximal phalanx. And
exactly.
and so the and that's why I think that you do the fixation of the middle phalanx first. Is that right? Before you do the proximal phalanx fixation, which is a more challenging fixation.
I think I try to fix from the distal to proximal. One is to make sure the arc of motion, the fraction of the digit. After the reconstruction, the digit will going parallelly in fraction. So I try to make the distal fixation first and then finally to adjust at the proximal phalanx to make it able to have a good inflection and acceptable in extension.
Yeah.
So that's why I studied from distal to proximal.
Right.
It's not really about the mismatch of the proximal phalanx that make the fixation more difficult, but I just want to know how the finger flex in a good axis.
I see. And can you explain to us and for the audience how you fix your skeletal structures? You mentioned about the cerclage wire fixation.
Yes, I we actually use the point zero 0.026 millimeter wire for the fixation, and basically we just using the drill to make the tunnel at the middle phalanx and the proximal phalanx. And in the middle phalanx level, we do it as a parallel wiring. So two wire will be fixed, and we use the same drill tunnel at the toe, and using those two holes to fix the fatal tendon, because we noticed that for the toe joints, actually they do not have a good central slip inserted onto the middle phalangeal base, but always the patient will have a good lateral tendons, lateral bands of the toes. So we just trying to fix the lateral tendons onto the peroxisome, onto the bone. So we just using the suture, tie it over to make something that inserted onto the middle phalangeal base. So when we repair the proximal EDL tendon to the EDC tendon, then we do have something that really inserted onto the middle phalangeal base. So that be helpful in correction of the extension of the PIP joint. And at the proximal phalanx, we do it a very similar way, but just additional horizontal wire that make it a 90-90 wire, uh, along with two parallel wires. So
Okay.
I will have three wires at the proximal phalanx to make
Okay.
it more stable. Yes.
So the middle phalanx parallel circulash wires in the posterolateral antral axis, I suppose, and then for the proximal phalanx, the same, but this time with a perpendicular one going
Yes. Yeah.
transversely. Okay.
Yes.
Okay. Now, is it so? You did the you followed up these patients radiographically. Is it at 3 months and 6 months, and then 12 months
Yeah.
post-op? And you
Yeah.
noticed that you were tracking to see whether the malunion or the dorsal angulation was progressing.
Yes, we do found that. Yeah, in some cases, actually, at the beginning, that they were quite neutral in the alignment, but probably one at 6 weeks, we will follow the X-ray to find any initial healing of the bone. During our follow-up to 3 months, and they do have some progression of the angulation.
Mm.
Yeah, that do happen in those with the malunited cases.
Okay, and so are you able to predict which patient will go on to have problematic malunion or non-union, or is that something that is very hard to predict intraoperatively?
Actually, it's very difficult to predict. So far, we're still trying to studying that.
Mm,
And as I mentioned, that the laser Doppler fluorometry, actually, we use that for the post-op monitoring, but not do it in the intraoperative. Recently, I studied a new study that I tried to measure the laser Doppler fluorometry in intraoperative. Then probably from that could give me some hint that who might have the risk of malunion or non-union in the uh, in the follow-up. So yeah, that's
yeah,
a study that we try to identify who could be the risk
yeah.
for that, and probably we have to analyze even the diameter of the recipient artery and the pressure of the median recipient artery. Probably the flow also will be related to the perfusion of the joint or even the bone.
Mm,
So for that condition, then you can imagine if those perfusion is not as good at the beginning,
mm,
probably they would have chance to have the malunion, non-union. Or in those cases, technically, we should be more aggressively plating for the joint is not as easy. That to have more rigid fixation is not as easy. That plating, actually you do not have enough space to put a plate on the toe joint, because the toe joint usually probably I would take about 23 millimeter in length. That's about 1 centimeter at the middle phalanx level and 1.3 centimeter at the proximal phalanx level. So to have a good plating of that is rigid fixation of that is not as easy.
Yeah.
But maybe for those difficult cases, probably we can add additional bone graft inside intramedullary to stabilize it or something. Yeah, we can try the other method that to make the union um, as
Yeah,
as
more predictable.
as normal as possible. Yeah, yeah,
Yeah, yeah, okay. But nonetheless, what's interesting to me is that half the patients, or roughly half the patients who had malunion or non-union didn't need further corrective surgery. So how did you, what were your indications to do further surgery for these patients?
basically it's well, it just I accumulate the experience from the previous cases. For some cases that they had more severe malunion, probably uh, they have the 20 degree of or even 30 degree of malunion. They still have a pretty good in the result. That actually is out of my imagination.
Mm,
So from those cases, I will consider correction uh, will be more conservatively. I will delay to do that. So for those cases who have a very severe malunion, that's such as more than 30 degree of in the union, then probably I still do the correction osteotomy along with the tenolysis
hmm.
in 6 months after the surgery.
Okay.
So yeah, I would delay to do the correction.
Right. Okay. So you take a quite a cautious approach and see how the patient gets on first and see
Yes.
whether how their function is and not necessarily be guided just by the angle.
No.
Okay. Okay. And also, can you tell us a bit more about your corrective techniques?
I just do wedge osteotomy, and for the osteosynthesis, I will using the K wires for the fixation.
Hmm.
So using a pin to fix it, and just like ordinary fracture cases, I frequently using the K wire for the fixation for the bone fractures. Yeah. So
Bone
for the
grafting?
correction, grafting, no.
No.
No. Yeah, we don't really need grafting. We just correct the angle. So usually we don't need a graft.
Great. Okay. And so you've been meticulous about measuring all the angles post-operatively to get really good objective data, and it's amazing that you're consistently getting, I think, an average of almost 60 degrees range of motion post-operatively. Um,
Yes.
there were a couple of things that I wanted to ask you. One comment you had in the discussion is that that you think this mode of reconstruction is superior to implant arthroplasty. Can you tell us why
Yes.
you think that? So these are for post-trauma patients, just so the audience is clear about this.
I think that at this moment that most of the hand surgeon will believe that the arthroplasty probably can improve the pain, but not really improve the range of motion. So no matter which kind of material you use for the implant, so actually the actual range of motion won't be really improved. And especially the drawback of the arthroplasty, probably they are especially weak in the radial digit, that's in the index and also including the middle finger. It's not stable for the side pinches. So, but for the vascular joint, actually is as stable as a finger joint. So the side pinch is not a real problem. But for the ulnar digit, actually, arthroplasty still could have pretty good in the result. But in some experience, surgeon, they will notice that I think for those cases who can have a good outcome in the arthroplasty to using the implant for the correction, and in those cases, actually, I I believe that the authors or the senior surgeons, those experienced surgeons, they do have uh, uh, their indication how to choose the good candidate for the arthroplasty. So it doesn't mean that arthroplasty doesn't cannot be compared with the vascular joint. But well, if you select a good case, they would have a pretty good in the outcome.
Mhm.
Yeah, patient could have some satisfactory outcome. But of course, that I would say that vascular joint transfer, probably I would suggest for the patient that is relatively younger and active adults, and they probably need the joint to work for them. But arthroplasty, so far, for some cases, you still get pretty good in the grip and pinch part, but it's not happen in every cases. So, but in the joint, well, with this autologous joint transfer, I believe this outcome will be very consistent and lasting much longer than the arthroplasty.
Ike, have you got any thoughts on that?
Yeah, I think for the if the question is talking about the indication of arthroplasty and also the compared to the vascular joint, I think majority professor has mentioned it's like the collateral ligament of the ulnar digit would have better stability using the vascular joint transfer because it's more physiological and also more reliable in case of like collateral ligament strength. The patient may have higher chance to stabilize when they do the side pinch. And also, I think one of the strength of vascular joint is if the patient gets early injury during their, for example, like in their adolescence or the young adult active, they might need a long stabilized of autologous vascular joint transfer
Mm.
compared to the arthroplasty because sometimes when time pass, the hardware will wear down and you might need a revision surgery in the future. So I think that's also one of the advantage that vascular joint transfer can offer for the OA PIP joint.
So a more kind of functional with in terms of range of motion and ulnar stability, more and a longer lasting outcome potentially. So okay, and the other thing was we talked about how you've been meticulous about getting objective measurements, but I wonder you haven't included this in your study, but what was the patient's experience of the, I mean, we talked about a small number of patients who went on to have malunions, but actually most of your patients don't have that problem. They have fantastic outcomes. But can you give us a sense of how this operation has impacted your patients?
Actually, I'm not a very aggressive surgeon that doing a good clinical studies. So I did not use those questionnaire to measure those patients. But well, for my patients that they came to us, actually they have the post-traumatic arthritis. They would either have stiffness joint or they would have some painful joint. So basically, I would just notice that they would be able to go back to their original work. During the follow-up, I will continuing asking any problem that when they doing their work, and most of them actually do not experience any difficulty after years of surgery. So I believe that in general, that patient satisfaction rate is quite high, and donor site mobility is really, really low. That of course there's long scars on the foot, but for the ambulation, they're walking, they're climbing, they're hiking, or they're running. Actually, they do not have problem with that. They can jog very well. So donor site mobility is low, and the recipient actually have a pretty satisfactory long-term outcome. So
You've been at this for many years now, Professor Lin. You have charted along the way landmark refinements. Is it possible for you just to very quickly summarize for our listeners what are the key steps that have allowed you to really get the most out of the vascularized joint transfer?
yeah, I think the difference of our surgical technique should be more emphasizing on the extensor reconstruction at the same time during your joint transfer. I think vascular toe joint transfer technique is just kind of similar to a toe transfer for those dissection and the vessel repair. But the only thing that we miss in the past is that we didn't realize the difference of anatomy of the central slip, the difference between the finger and the toe. So if we neglect that, of course, the patient do not have a central slip. No matter how tight the extensor be repaired at the surgery, well, we still do not have a central slip to extend the PIP joint along with the lateral bands. So the most important thing during this procedure, actually, I would say that focusing on dissection of the finger extensor, preserving those which can be used in then incorporate with those that we can harvest from the toe to make a very similar extensor mechanism, like the native original extensor mechanism. Then the extension will be easier to be achieved. But for the fraction, I'm not too worried about the fraction of the patient of the finger. Uh, because in our experience or in the literature review, actually, you will be very easy to find out that for almost every series of the vascular joint transfer, they do not have a problem at the fraction. Almost always, the patient could flex the finger as they can flex the toe. So I will measure the passive motion before the passive motion of the toe before the surgery. Then I will before the surgery. Then I can expect how many degrees that I can get after the surgery. So basically, reflection is not a problem, but we try to focusing more on the extensor reconstruction. Then I think everyone could get a pretty good uh, outcome in the range of motion.
Fantastic. Well, there we have it. The vascularized PIP joint transfer, how to get the most out of this reconstruction, and how actually having a bit of dorsal angulation post-operatively is surprisingly not a factor in giving people bad outcomes. So thank
Yeah.
you so much, Dr. Ike Lee and Professor Ted Lin. Thank you very much for all your time.